Well, good morning, everyone. I decided to present on scoliosis today. It's kind of a focus on some of the stranger theories. You know, I'm interested in scoliosis mainly just out of curiosity, because I think you know, when we have something, especially something with the word idiopathic before it, we're talking about idiopathic scoliosis, meaning we don't know the cause of it. You know, that's you know, it's kind of like you know, new horizons or new discoveries to be made out there. So you know, it's constantly being studied, and you know, it's something that we've known about for thousands of years, but we still know very little about the etiology and how it begins. So what is scoliosis? So scoliosis, the word derives from the Greek scolios, meaning twisted or crooked. And it's defined as a lateral curvature, so a curvature to the side of the spine more than 10 degrees. And the way that's measured, the most common measurement is the Cobb angle. I have a couple pictures of that below here, but so curvature to the right, so meaning the convex surface, the way the curve points, basically. Curvature to the right is called dextroscoliosis. It's much more common than curvature to the left, or levoscoliosis. And most people, most of the people in this room have a mild curvature to the right of, less than 10 degrees. And it's thought to just be a physiologic phenomenon where it's just kind of making room for the lungs and the heart on the left, that take up more space on the left side. So I remember the first X-ray I saw of my thoracic spine, I was kind of taken aback. I thought I would have this perfect little, upright spine, but no, I've got that little curvature there. So the Cobb angle is measured by taking a parallel line to the end plates of the top and the bottom vertebrae of the curve, and then you take perpendicular lines to those and measure the angle between them. So is it a problem? It's a very common condition. There are more than 3 million cases in the U.S. alone each year, and approximately 25% of the curvatures progress over time, while the rest, about 75%, are stable. So so it's very common to have a curvature and then just have it not progress any farther after skeletal maturity, after you reach adulthood. So in minor curvatures, less than 20 degrees, most agree that no bracing or surgery is required. But in more severe cases, lack of treatment can result in chronic pain and body image disorders, and even heart and lung damage due to just the pressure of the deformity of the rib cage, reducing the space for those organs. That's very severe scoliosis. So what causes scoliosis? Well, I took this out of my radiology textbook. So there are many, many different causes. There's structural, there's neuromuscular, myopathic, congenital. Just about every type of etiology of disease in the spine can potentially cause scoliosis. You have neurofibromatosis, rheumatoid disease, trauma, infections. You have tumors, metabolic disorders, and postural nerve root irritation. So many different causes, but the most common type is the idiopathic adolescent scoliosis, or IAS. So most often occurs between the ages of 10 and 12 or in the early teens. Girls are much more likely than boys to develop scoliosis. And while any one major cause for the scoliosis has not been identified, there are two main schools of thought about the origin of scoliosis, how it starts. So you have neuromuscular causes. So it's the first school of thought, and probably the most popular one at this time, is the neuromuscular factors. So meaning proprioception, the vestibular system, and basically like postural control of the muscles that control the spine and hold the spine upright have somehow been thrown out of whack. So something's gone wrong, either in the central nervous system or at the muscular level, or the peripheral nerve level. Nobody really knows exactly. Or it could be any one of those. Just there could be entirely different populations within this this whole theory. So awareness of the body's position in space results from signals from the vestibular, the visual, and the proprioceptive nerve pathways. The brain seems to take information from the eyes, from the inner ear, and from all the connective tissue, muscles, bones, joints, and adds it all up in the brain and makes these coordinates of where, even with my eyes closed, I can tell my hand's off here to the left, somewhere above my head, So now along these lines, many scholars and researchers believe that the primary driving force behind idiopathic scoliosis is basically disafferentation. Something is wrong with one of those sensory processes where you're getting kind of incorrect input from either from the proprioceptors or from the vestibular pathway or from the eyes or from the visual pathways. And that's leading those muscles in the spine to contract, more on one side than the other, and you end up slowly with this lateral curvature of the spine. So faulty proprioceptive input from the soft tissues of the spine and defects in the muscle spindles have also been implicated. There is an increased myoelectric response, so meaning in scoliosis, there's more activity basically in the muscles on the side of the curvature. But again, even among the top researchers, they can't agree on whether this is from those muscles being too active and pulling the spine over there, or if it's from them being stretched and from muscle spindle activation from the overstretching of those muscles. Yes?
I'm assuming that the handedness of a person would be correlated with the extent of activity on the handed side, the preferred side. And if that's the case, then wouldn't one find, even in a very small degree, a certain amount of scoliosis, a higher percentage in right-handed people on the right-hand side, left-handed people on the left side?
I haven't heard about that, about whether left-handed people are more likely to have a left-sided curvature.
Well, that would be a test of that theory.
Yeah, I'm not sure about that, but yeah, that is an interesting thought. Yeah, I'll have to look into that. All right, so I mean, this is kind of a summary of what I was just saying. You have the visual inputs and the vestibular inputs, and then input from the ligaments, joints, muscles, all going to the central nervous system, which then controls these postural muscles in the spine. And if something goes wrong with any one of those three, then possibly that could cause a scoliosis. And then the other theory, which is it's more of an older theory from before we really knew that much about postural control and proprioception. And a lot of it's been kind of disproven in the last couple decades, but so the other major school of thought has more to do with biomechanical issues, kind of the idea that during development, because this does happen during adolescence, during the fast growth periods, that if you have an uneven growth of a vertebra, just slightly, then that can cause a biomechanical imbalance where the weight is shifted to one side, and just over time from walking and from the repetitive forces, you're going to be moving the spine off to that one side. And so there is some decent evidence behind some of these theories. There's the apical vertebra, meaning the vertebra at the very point of the curve, at the apex, is they found that the body of that vertebra is slightly taller than in the front than in the back. So that leads to kind of a thoracic lordosis, meaning your thoracic spine is supposed to be curved this way, but for that vertebra, for that location, it's kind of in the opposite direction. And so they kind of theorized that because of that oddly shaped vertebra, your body's reaction is to try to get it back into that kyphosis, into that forward flexion, and so that leads to the rotation and the lateral curvature. But again, these are very difficult theories to test. So, all right, so branching out from these two schools of thought and from things like genetics and micro and cell physiology and things like that, you get an extremely diverse set of theories about what causes idiopathic scoliosis. And so I'm about to outline some of these. These aren't necessarily the leading theories. These are more just the ones that I find the most interesting. So so the theories range from, okay, that could happen, to, okay, I'm going to slowly put down my bagel and make for the door. All right, so vestibular dysfunction. I already talked about that a little bit. So individuals with scoliosis also tend to have postural and oculomotor deficits. So this has driven research into vestibular causes of scoliosis. As early as 1979, they did ENG studies, electronystagmographic studies, basically where they put electrodes on the head. The people follow these dots, and so they measure eye movement. And so they found that right-sided scoliosis, so the curvature goes to the right, that was associated with higher sensitivity of the right labyrinth. And likewise, left scoliosis had more sensitivity in the left labyrinth. Using advanced imaging techniques, researchers pretty recently have been able to detect some shape differences in the vestibular apparatus of scoliosis patients that correlate to the side of curvature. So there's some kind of tiny deformity in the vestibular apparatus on the same side as the curvature, according to some of these more recent imaging studies. Proprioceptive dysfunction. So researchers have measured the proprioceptive accuracy of patients, meaning they'll bend somebody's wrist or elbow or knee and determine if the patient can distinguish between just a few degrees of flexion or extension. And they found that people with scoliosis have not as accurate proprioception both in the upper and the lower extremities. Leptin. So a 2007 study published in Spine found a marked decrease in circulating leptin in scoliotic girls. Leptin is known as the satiety hormone. It's produced by fat cells to inhibit hunger, and normal trunk widening. It's a very complicated pathway, and this is only something that was discovered in the last 10 years or so. But trunk widening is partially regulated by the sympathetic nervous system involving leptin receptors in the hypothalamus, and hypothalamic sensitivity to leptin may create skeletal abnormalities or anomalies. Now this one I found really interesting. Melatonin, it really grabbed my eye at first because the initial study was done with chickens, and I don't see too many animal studies with chickens. Do you, Richard?
No, only at Colonel Sanders.
Yeah. Yeah, I don't want them experimenting with my food personally, but so they used 90 chickens actually. So 3 groups of 30, and so the first group they took out the pineal gland and just tossed it out. The second group they took out the pineal gland and then they reinserted it into the abdominal muscles so that it would continue to produce melatonin. And then the third group, they was the control group. They didn't do anything to them. So in all 30 of the ones where they took out the pineal gland and tossed it out, they all developed scoliosis. And so in the group where they took it out and they put it back into the abdominal wall, they only about 10% of these chickens developed scoliosis. So they kind of theorized from that maybe the people who are developing scoliosis have low melatonin because the pineal gland secretes this important sleep hormone. So 10 years after that study, or no, let me see, here we go. 3 years later, a study was published measuring melatonin levels in normal and scoliotic adults. And they concluded, whereas pinealectomy in young chickens leads to reduced melatonin levels and the development of scoliosis, the results of this study suggested melatonin levels in mature patients who already have severe scoliosis do not differ from healthy subjects. And it's also been measured in younger adolescents who are developing scoliosis, and there's really no difference in melatonin levels. But 10 years after, another group of researchers measured the metabolism. Oh wait, no. Also, I'm not saying but, because this is agreeing with the other one, but 10 years after, another group of researchers measured the metabolism of the pineal glands of scoliotic versus normal patients. And they also found no difference between the two. So basically it's been well documented that people with scoliosis and people without scoliosis produce the same amount of melatonin. And their pineal glands are the same. So that's the end of the story, right? Well, while melatonin levels don't appear to differ in people with scoliosis, a study in 2007 examined a gene for the melatonin receptor 1B. Now they found polymorphisms of the promoter of this MTNR melatonin receptor 1B gene associated with adolescent idiopathic scoliosis. So this polymorphism can predict whether somebody is going to develop scoliosis or not. So while people with scoliosis produce the same amount of melatonin, their melatonin receptors are different. So they might not be as receptive or as sensitive to melatonin as normal people. So I mean, the jury's still out on whether melatonin has anything to do with it, but it appears that melatonin receptors or some kind of modification of the receptors could lead to the development of scoliosis. And then this year, 2015, a systematic review analyzed 4 papers on the polymorphism I just mentioned and supported the association between the gene and scoliosis. All right, now here's where you might want to start putting your bagel down and walking toward the door. So dental occlusion. So dental malocclusion is misalignment of the jaw, basically, or where the teeth do not fully close. And a 2011 review published in the journal Scoliosis analyzed 23 cross-sectional studies and concluded that there is plausible evidence for an increased prevalence of a certain type of malocclusion associated with scoliosis. Now, in an animal study, researchers they took 15 rats. They put this bite pad in to kind of induce a malocclusion, and in all 15 of the rats, they got scoliosis. And then when they took out the pad, the scoliosis went away in the majority of them, 83%. So you can imagine there are probably a lot of dentists and orthodontists out there who would love to see this turn out to be something where, if you fix the teeth and you fix the spine, that'd be really good for business. All right, now treatments. As far as high quality evidence for conservative care, there really isn't that much. Bracing and surgery are the only treatments with solid evidence for stopping or reducing curvatures. Physicians will typically observe and measure the progression before resorting to anything invasive. While only a small percentage of adolescent scoliosis will reverse on its own, something like 3%, I believe, is what I read. Actually, you can have a significant scoliosis and then it will actually reverse itself without any treatment. The majority of cases do not progress to a point that causes disability. So, most cases, they progress to a point, they stop at, say 20, 30 degrees or so, and that's not enough to really cause any kind of deficit or any physiological change, other than possibly body image issues. People. So predicting progression. Now, just last year there was a very promising study that using some advanced computed imaging techniques, it's actually using plain films, using an A to P and a lateral X-ray, but using like 3D computing software to make a 3D image of the spine, and to actually see those curvatures in a three-dimensional way. So these researchers have possibly discovered a couple of factors that physicians could identify whether or not a curve is going to progress on the first visit without having to observe and take x-rays again and again. They might, and this is like level 3 evidence right now, but they might be able to predict from one set of x-rays whether or not that curve is going to keep progressing or if it's stable as it is. So the two two factors they identified were or that the angle of the plane of maximal curvature was higher in progressive scoliosis. And they also found a 4 degrees smaller kyphosis in progressive scoliosis. So, so to kind of see, oh, hold on, okay, got that mixed up there. But so the angle of the plane of maximal curvature is basically this. So they find the area of the spine where the curve is like at the highest slope, basically. You draw a plane through that, and then they measure the angle. So in progressive curves, this particular measurement is about 12 degrees higher than in non-progressive scoliosis. All right, now alternative and conservative therapies, while these are very popular, they have little or conflicting evidence to support them for reducing curvatures. Now I say, with a caveat, that's reducing curvatures, but many patients with scoliosis who have pain from the scoliosis, and the pain can, definitely be helped with, things like massage, manipulation, exercise, stretching, that kind of thing. So while there isn't really much evidence to support reducing the curvature, some of the symptoms of scoliosis can be eased by conservative care. All right, and then let's have a little. These videos didn't work last time, but we'll see. Oh, it's actually working. So this is
the Schroth Method, developed in Germany in 1927, was by Katerina Schroth for her own scoliosis condition. This method is a conservative method of treatment which works with exercises that elongate the trunk, correct the imbalances of the body, and use a special breathing technique to change the shape of the thorax that has been affected by scoliosis. It has become the premier conservative treatment for scoliosis in Germany and is reaching all corners of the globe. The method develops the inner muscles of the rib cage to change the shape of the thorax, to create a correction of spinal deformity, decreasing pain, slowing or halting of progression, and improve cardiopulmonary function, also improving mobility and postural stability. The patient is taught to put their bodies in certain positions that would enable an expansion of the flattened chest and back areas. Through many repetitions and proper positioning, the patient develops a new awareness of their posture and alignment. Many scoliosis patients have a flattening of their backs as a result of the curvature. We encourage exercises that increase the kyphosis, and have many of the exercises include this component. The exercises are performed in many postures: sitting on a ball, lying face down, face up, and on their side, as well as many standing postures with sticks or bars on a wall. The combination of exercises is determined by curve pattern and severity. After completing an intensive training with the
all right, so there are lots of techniques out there. This is one of the most popular, specifically for scoliosis, and it's a very interesting theory that if you can control breathing patterns and consciously gain more control over the postural muscles of the spine. I've also seen videos of people who have gone through the Schroth Method, and they have very severe scoliosis, but they seem to have more control over it, where they can actually straighten out. But of course, as soon as they lose their conscious straightening, it goes back to normal. Of course, when they go back to sleep, they're not going to be straight anymore. So it doesn't entirely fix the problem, but this is one of the more researched, more evidence-based conservative treatments. But again, there's not a lot of high quality evidence supporting any kind of reduction or permanent reduction of curves. So. And that's why that was out of order there. Okay. All right, so in conclusion, idiopathic adolescent scoliosis is a complex conundrum that may never have a simple or singular answer, but each new study represents a tiny piece of a puzzle that may realize advances in prevention and treatment in the years to come. All right, so I hope you all enjoyed that. I always keep my eye open for any kind of new breakthroughs, but it's a very complex situation, and ever since Hippocrates was using mechanical traction on his patients for scoliosis, we haven't really advanced that much since then, to be honest. But we're always learning a little bit more from day to day. Okay.
Thank you.
Thank
Good.
you.